And a big thank you to the organizers for allowing me to present our very basic research. I think all of us have had this situation 1,000 or even more times in our professional life. Doesn't work? Oh. Patient comes in your, sorry, can you go back again? Oh, I go back. Yeah, you're explaining some exercise to your patient, showing some things, give him some information about posture, about the nature of his problem, telling all the stuff in your first evaluation. And then you send your patient home. And then you have the same situation, what's going on here? 1 day later, 2 days later, maybe a colleague is looking at this patient, or yourself. Your colleague told me that. And you wonder, what's going on here? I think we all had this situation, and we are asking ourselves, do our patients really understand what we think that we are telling them? Okay, that's a very basic question. And we thought there must be some evidence in the literature about that. Actually, there is some stuff on communication, mainly about communication from doctors, physicians. And that's not very promising. A lot of misunderstandings. Fear-provoking ideas. Acute for a patient doesn't mean less than 7 days. It means that's really bad. It's really threatening. And physicians don't do well with the elderly and with chronic patients in explaining stuff. They don't communicate well. So what about the physical therapists? How are they doing? And also, not very promising, if you look at the literature. We are good in providing exercises, in telling patients about exercises, but there's no research, actually, we didn't find some, on this very basic first evaluation day, does the patient really understand it? So we decided to run our own research project on that, and just ask this question, or answer this question. So what have we done? We looked at patients with back pain, because on back pain we have the most studies all over the world, most research is done on communication, doctors and back pain patients. So in the first session, first evaluation, first day, we provided the patient with a form after the initial assessment, and the patient was asked just to write down, what has this therapist told you? Which information, which exercise has he given to you? And what do you think, how relevant is it for you and your problem? And we asked the patient, were your expectations fulfilled? That the ones you had coming here for day 1. And then we did the same with the therapist after initial treatment. We asked him, which information have you delivered to the patient? Which exercises have you delivered to the patient? What do you think, how successful did you provide that? Did your patient get the message? And how successful was day 1 overall, concerning your goals for day 1, whatever they were? And then, after that, we looked at both questionnaires, compared them, and looked for discrepancies. So, and when there were discrepancies, we conducted interviews, used a topic guide for that, to find out what went wrong in this communication. And our hypothesis and our experience was that goes a lot wrong. 5 clinics took part in that research project, and here are the demographics from the therapists, mainly McKenzie trained therapists. The patients, we included 92 patients in that study. That's quite a lot for a quantitative study. Most of them were chronic. Some subacute, most were chronic. First we had to decide what's an exercise and what's an information. And so we said, exercise, that's everything we can put a number on, 3 times a day, 10, or whatever. Information, as soon as we deliver some information, let's give them a booklet or give them some information on postural advice, that's information. So, very easy. First, we looked at all these 92 questionnaires from the therapists and look what was the one main exercise they have given to the patient, just for the top one. And then we looked, do we find this exercise also in the patient questionnaire? And surprise, we found them in 91 cases. So let's say in all cases, the patients wrote down almost, not using the same words, but wrote down this exercise. And we were really surprised by this one. We didn't expect that, not at all. But it's not about only recite it, it's also about, do you think it's relevant? So we ask also, is it relevant? Is this exercise or information exercise relevant for you? And the next surprise, yes, it is relevant. None of them said it's not relevant at all, or it's irrelevant or whatever. So, good results. The next question was, can the therapist predict if he's successful in delivering the message? And also here we found, prediction was quite good. Only 13% overestimated what they did. And it came to information also. How good are we in delivering information? Or how good does the patient hear the information? In some cases, maybe no information has been given. So in 82%, the information was heard by the patient. Good, great. So overall, looking at these numbers, at these graphs, that's really promising, isn't it? But we have a problem here. Because our hypothesis and our experience was communication doesn't work. It doesn't work. But in this case, we've seen it works. Damn, they are not too bad in communication. So the next question was, why? Why does it seem to work in this environment? In this environment with our clinic, mostly our clinic, I have to admit that. So why does it work here, in these circumstances? So now we conducted the interviews, but not to find out why communication failed, but what may be the reasons why it works in this environment. And so we conducted 15 interviews, most of them in the clinic, some of them were telephone with the Swiss patients, for example. And we found 4 themes. The first theme, and maybe the most interesting one, is the way of assessment. We found this in almost all interviews, this theme, the way of assessment.
Wie ging's mit dem Therapeuten?
Gut, hat er auch gesagt, was ich habe. Und wir haben die Übungen zusammen miteinander ausgearbeitet und probiert.
Okay. So, and now you can read a few quotes and watch out which words you find repetitively. So I think you can identify that we did, and we found out, and then we made that. And shared decision making is a term very often used and highly appreciated in medicine. And it's mostly about therapy. How to treat that diabetes, how to change the medication together with the patient. And we learned yesterday from Georg that MDT is not very good in that. And MDT doesn't do well. So, unfortunately, he's not here anymore. So, but in our study, what we found is patients highly appreciated that they were involved in the assessment. So we found together the diagnosis. There's no one sticking a label on you and saying, oh, you are that and that, you have that mobility problem here, or the instability. We found it out together. The diagnostic process is together. And maybe Georg has to change his training. So the second theme was exercises.
Wie hieß die Übung? Die Übungen sind einfach, ich konnte es auch ganz gut merken und vor allen Dingen auch in Alltag gut einbauen.
Good. This may sound somehow familiar for you. Okay. So we found that patients appreciate simple exercises, simple advice in this direction, can include in daily life. Worries about back pain was the next issue.
Machen Sie sich eigentlich Sorgen?
Ja, schon, weil der Schmerz kommt und geht und ich weiß nicht, was da los ist.
Yeah, patients are afraid. We found that theme very often, almost also in all interviews.
Ja, ich war auch schon Sorgen in meiner Rücken, aber seitdem ich gemerkt habe, dass ich da aktiv was dagegen machen kann, eben eigentlich die Sorgen schon ab jetzt.
So the assessment really helped this guy to get rid of the fear. Yes. Sorry. So address the fear is our conclusion from that theme. We have to address these fears. Sometimes patients don't mention it. And the fourth and last theme is expectations. What expectations did these patients have? This goes on. Yeah, makes more sense. The next one is also very nice. This may remind you on produce no worse, stuff like that. Our MDT tools seem to be not too bad for that. So ask for expectations. Don't miss them. Yeah, good stuff, isn't it? But talking about prognosis with patients is a really important thing. We know from literature. And in our study, it was not a topic of our research, but we found it more a side finding. Only in 16% of all cases, therapists provide a prognosis to the patient. Good. So limitations. There were some. We are biased. In qualitative research bias, that's an issue. The Hawthorne effect. As soon as you monitor human behavior changes. Patient and therapist, they knew that they have to fill out a form after the evaluation. Consecutive, sorry, you can read that. It's hard. In a perfect world, we would have done it this way. But in our world, we don't have a receptionist, we sometimes forget to ask, we were busy, so we didn't include consecutive patients. And the external validity of this research is low. More than 80% of the patients were evaluated in our clinic, and all of our therapists are McKenzie trained. And of course, it's also about sympathy and objectivity. The interviews, we realized that, especially when we interviewed patients from Switzerland. They had a feeling, oh, Big Brother from Germany is watching us. And we can't comment on efficacy and outcomes. No comment on that. We started with a tiny little bit at the beginning of our assessment process. Conclusion: yes, it works. It seems to work if you do the assessment together. That seems to be very important. The exercise has to be simple. Address the fear of your patients and ask for expectations. So, thank you. And watch the next slide, the next video. Research can also be fun.
Hast du die Übung gemacht, die du jetzt gerade heute vorgeschlagen hast?
Ich hab's vor, aber zur Zeit habe ich Urlaub.
Yeah, that's daily life, isn't it? Thank you.